But when we do humeruses for an adult, we want to have it open to a 14 by 17. And I normally do this the first thing before I have the patient up against the wall buffy. I already have my 14 by 17 portrait. Okay? Okay. So, can I use you real quick? You're closest to me?
Yeah.
All right. Perfect. I'm just going to adjust to her size right now. Nothing's permanent. I'm just moving the bucky. Pretty sure you guys already gained how I normally do these things now. So I'm just eyeballing it for right now. The diagonal of the image receptor is a lot longer than the actual length. So this 17-inch right here, this is a lot longer going diagonal. Okay? So what I'm going to try to do is I'm going to have the patient off-center. I'm going to move it a little bit over to your right. There we go. So I'm going to get that humerus probably in that corner there. Okay? Next thing I'm going to do is I'm going to bring the arm this way up towards me. Let's bend that elbow. Boom, just like that. I have a lot of light down here, okay? Makes me a little nervous. Maybe I don't have enough light on this shoulder. So I like to have at least about an inch or so below the elbow. There we go. Just like that. I feel pretty confident. You can get her in real easy. Epicondyles are parallel to the image receptor. Central ray is going to be at the humerus. I'm going to now extend the light out because again I have a lot more light here diagonal. And I'm going to collimate in. Not too shabby. Let's put that left marker there. Look at that going down the axis of Reyna. That's perfect. So this is a AP humerus. Look at that. Arms nice and straight. AP humerus. Okay. And then we're going to do a lateral. I'm going to rotate her arm in. Look, I'm feeling those condyles. Let's rotate that arm. There you go. That's a good rotation. Those condyles nice and perpendicular to the image receptor. I'm not going to mess with my collimation. I'm not messing with my marker. Unless, for example, her arm went this way, just bring it back down. Not hard. Okay. Let's hold still there. Don't move, don't move. Okay. Good job. Good job. You can relax.
Okay.
Thank you. You want to show someone else? You want to see it?
No, it's okay. I think I got it.
You got it? Okay.
It's the lateral, right?
That was the lateral, yeah. You sure? You good? Okay. So that was the AP humerus, and then the lateral humerus. Okay, so those condyles, you saw me manipulating it. I was rotating it, turning it in. Okay. Did you get to see it? Okay, fantastic. All right. So next is going to be the trauma humerus. They have two views as well. We have the AP and lateral. So can you hand me that black sponge, please? Thank you. All right. So for your test, you guys will be able to use a sponge for the humerus, and you need it to because we want to have it at least put away from the body. Okay, because you saw that how I had the arm extended this way. That's away from the body. But with trauma, usually we can't move it very much, but sometimes we can, and we will use a sponge. Okay. So let's do that again. We'll use your left arm. I'm going to have you go ahead and nurse it for me. There you go. You can hold it with your other hand. There it is. There's that true. But she's although she's trauma, she's sticking out away from the body. That's a treat for me. But you know what? I can't let it be that easy. So let's use that sponge. There it is. Now that is an injured arm. I'm going to rotate her. I'm going to turn as an oblique here because those condyles need to be parallel to the IR. Let's rotate you some more. Here we go. I'm going to line up the central ray to her humerus. Look at that long axis just going down her bicep. What a treat. I know already just from the previous I positioned her that this is going to fit in. So it's kind of a little bit unfair. But the thing about it is I'm still looking at the length here. Her elbow's right there, shoulder's right there, so I know I'm going to get her in foot. It's so easy. I still feel she's a little off-centered, so I'm going to move her over slightly. There it is, just like that. Okay, nice and straight. You have to turn the patient oblique to get those condyles parallel. Okay, right, my left marker placement, just like that. Okay.
So it didn't seem like you changed the light. You just went on into this one.
Yeah, you know what? Let's do it this way. I'm going to use you as trauma. That was just way too easy. Thank you so much. I appreciate it. Let's switch it up.
They're not trauma. That's why he didn't change the light.
Yeah.
Yeah.
Let's see. Let's switch it up. That was just too simple. You guys need to see something different.
Well, Let's do it for the test.
Let's see. So he's now the patient. Let's do the left arm there. There we go. Go ahead and hold it with your other hand. There you go. Let's put that right in there between. Boom. There you go. Gonna keep you. Gonna rotate your body. There we go. There we go. Just a smidge. Excellent. Good. Okay, I can't cheat this time. I don't know where it is. I don't know what's going on. If his elbows there, shoulders there, this guy's gonna fit in easy. My goodness. You guys are making this all easy for me. Look at that. I'm constantly touching. I'm constantly reviewing, ensuring that I'm going to get the anatomy in there. I'm not scared. I'm not going to do anything to hurt him, but I do need to make sure that I want to make only one exposure, and one good one at that. Look at that. Those crosshairs. I love it. Collimation is the last thing you're going to do, ever. When you're done centering, when you feel confident like I am, when you're just like, hey, this is going to work, there it is. You're gonna hit the light. There it is. You're gonna collimate last. That's your finesse. Okay? That tells me that you're happy with your centering, you're happy with your positioning, and that collimation is key. Okay? Left marker there, his elbows there, shoulders there. I love it. Easy for him. Let's switch over to the right arm, okay? So I'm gonna have you nurse the right arm. We'll switch the sponge around. We're going to do it this way because it's a lot easier for me to demonstrate. So now we're going to go into a lateral. All right, so I'm going to have you turn around, facing that wall for me. There we go. All right. In some cases, we're able to pull the arm away from the body. See how it's still tucked in there? Nice. Well, I'm just going to I'm going to pull back an arm a little bit, okay?
If you can't, you just leave it.
Exactly. But for this, he can. Okay? Oh, yeah, he can. And I'm going to force him if he can't. No. All right. I'm going to put him just like that. I'm going to move it over to your left a little bit. What I'm trying to do is get his humerus centered on the image receptor there. His condyles are already perpendicular to the image receptor. Would you look at that? Easy as it gets. Okay? But I'm a little bit worried about the light here. I'm a little bit, I might bring it down just a little bit there. I don't want to clip anything. It didn't require very much energy there. Centering needs to be on the humerus if I can. I'm going to lean him forward. Look at that. And that arm is flushed up against the image receptor. Are you happy with your centering? You're saying yes. Are you happy with your positioning? You're saying yes. Let's extend the line a little bit. Let's collimate in. Look at that. What a treat.
Wait, so the T should be...
Yeah, the crosshairs looks like it's really interior.
It really is. It feels like it's... But you know what? The crosshairs
Shouldn't
are...
it be way more over to that side?
There you go. There we go.
He's saying it's going to go through the body.
It's gonna go through the body.
Yeah.
It really is.
That's right.
But
So you're more centering off the Bucky crosshair as opposed to
very good.
the light?
I'm looking at the crosshairs of my Bucky right here, which is overlapped on his humerus. Okay, so that's gonna help me say, you know what, I'm centered over the shaft of the humerus right there.
So as
And
long
I
as you're
know
lining-
the way this looks. It's like, yeah, it's centering on your body, but you know what? A little bit's overlapped. It really is. But I'm looking at this right here to help me understand exactly where I'm actually centering.
Okay.
Oh yeah, because his back is going to make the light diverge weird. Because his back is more towards the light than it.
Oh, yes, you're right. Yes, in that sense, yes, you're correct. There we go. Notice how I had him lean forward so that his arm is now flushed up against the IR. So he was, if I had him pushed away this way, something like this,
Yeah.
it's too far. Not gonna work. Make it better. Make it better. Put him up against her. On your test, if you know whichever arm you're doing, you're gonna have to stick with that arm. I'm just only showing you the right because it's just easier to demonstrate it. That's
So
all.
if we're on the left, you want us to stick with the...
Oh yeah. Well, you know, I don't want you to like do the left AP like I did and then all of a sudden do the right lateral. I'm just doing this to show you because it allows you to demonstrate. Once you do the left, if you do the left humerus trauma, you're also going to do the left lateral trauma as well. You're sticking with the same arm. I'm only showing you the right arm because it's just easier to show you from here. Oh, that you have to go on that side to take a look. Does it make sense? Okay. Good job. Any questions regarding that? No? Take that away. So it's a lot easier to go ahead and set up for that 14 by 17. that nice white film, and then you just make your adjustments after that. Patience, positioning, centering, and then collimation is always your last. The last thing you're gonna do. Collimation is easy, man. That's why it's last. Okay. Let's jump into the. You guys want to see the shoulder? Yeah. Okay. Any requests? Anybody? No. I'll take some requests. No. All right. Yeah. All right. Yeah. What do you got?
We're not going to get tested physically on the transthoracic trauma, so we're not.
Oh yeah, man, you're gonna get that transthoracic trauma.
That's gonna be on the test.
That's gonna be on the test. I'll show that in a minute. So this is gonna be the routine shoulder. This one has 5 U's in it. The internal, the external, the Y, the Grayshey or Grayshey, and then the axillary. Okay. I know, man. I feel like I want some coffee too. So
I
bad.
got over here too.
You gotta be kidding. You got some?
2 cups. Yeah, hot and cold.
What? And you're still yawning though? Oh my gosh. I need to go get an energy drink. All right, here we go. So the book, the bone trigger states that you want to center at least about 1 inch inferior from the coracoid process. Okay. Now I can tell you this from experience. Patients don't want you digging into their shoulder when they're hurting you, and you got to dig in to find that coracoid. Probably one of the easier ways to do this is to actually go inferior from the clavicle. And I would recommend maybe 2 inches, not an inch, because then it would put you over the coracoid. So 2 inches from the clavicle would probably be a lot easier for you guys. Okay? So I can palpate his clavicle as long as it's not injured. Right about here, my finger width as far as this is about 2 inches. So I'm pretty close. I'm going to keep that. Not too bad at all. Jugular notch is here, because we do want to include that clavicle in it, and it makes it a shoulder girdle. I feel pretty confident about this. This guy, I can even collimate too. You're gonna get a lot of guys, you know, as far as like your body habitus, might not be so easy. So usually a 10 by 12, you're sticking to it. You're not gonna really want to collimate. I do not advise you guys collimate the length. You guys can collimate the width if you can,
Okay.
not the length. Why? As we saw on that thing right there, shoulder blades come in all shapes and sizes. You might clip the tip. If you do that, it is definitely repeatable. Left shoulder. Bring that arm out. Rotate. I don't have to bring it away from the body so much, but there we go. Condyles are nice and parallel to the receptor. This makes it a good external oblique.
Okay.
External rotation, excuse me. It's a long day, guys. External rotation. Okay? Please, don't move. Beat. Come back. Fill in those condyles. Rotate. Nice and perpendicular. Okay, hold it there. Don't move. Boop. Good. Great. Relax. There it is. Okay? Just 2 swift movements. At the external and the internal. Okay? Notice that I'm touching his arm. Notice that I'm touching those condyles. Right? Giving me the reassurance that I'm there. Why? Because when you guys look at your radiographs, you're also going to do the same thing. You're going to make sure that those tubercles are visible. All right, so we're going to bring this hand across your shoulder. There it is. Bringing that arm across the shoulder for the Y view is going to help try to separate that scapula from the thorax. And also, it's going to remove the humerus from the scapula as well. So it does 2 things. Don't forget.
And the higher you can get that arm up, the better, right?
I don't
if
know.
they can do it.
I don't know about the higher up the better, to be honest with you.
Okay.
It's just if they can really reach over, not so much the height, but if they can just reach over to the opposite side, the better.
Okay.
Yeah. Because you're going to get some people who are going to probably be able to just do this much, and then that's it. And you guys need to just obviously reach across the other side of the body, and that's all right. That's great. But a lot of times, just as long as they can reach the opposite arm, hold it right there, man. You're gonna make me do it.
I will take a lap.
No. So 10 by 12 portrait. Okay. Do not forget that was a big one last year. 10 by 12 portrait. Reason why is because the shoulder blade is very long. Okay. And that you're moving the patient away, it's causing magnification, making it longer. All right. I'm just going to feel for the medial border, and then I'm just going to use his AC joint to kind of line this up and use my hand to cup the back kind of gives me indication that this shoulder blade is now perpendicular to the image receptor. We're going to line him up a little better here. Let's get that humerus. There we go, right over the central ray. You guys can column it if you want to, but it's only going to be the width, not the length. Come down here. Maybe you want to ensure that you're going to get that tip. Not a bad idea. Look at that. It's right there. More than enough. Yeah. Forgive me. I have a little bit of light above the shoulder. That usually is my indicator that I'm going to have enough light down here. Okay. This one has don't breathe, don't move. You know, as far as it's a longer exposure, so as you can see, go ahead, just breathe normally. As you can see, think about it is, motion artifact is the most common one with these things. So just tell them, please do not breathe, do not move. Everything else is, it's okay, short exposure, so you can get away with them without giving too many instructions. You can go relax. Okay. So that was the Y view. Okay, that's going to come with experience. There are different methods to do the Y. There's like the bunny ear. I can't help you with that. I don't know how to do that. But it's like has to do with the medial border. Can you give me that skeleton, please? Maybe have you just step over that side. You can see it too. Okay, so it has to do. Maybe I can show you, but I just don't know if it makes any sense. Okay, so it has to do with the medial border. You're putting your hand back there like that, and then you put your finger on their humerus, and then you line up the two fingers like this.
Oh.
See how they're, if it's not, it's like this.
Yeah.
And then I rotate my shadow, and then like this. So that's what they say to do. There's the other one where you can put your fist behind their back, and that also is supposed to help you too. There are different methods. It's just whatever is going to work for you when you're out there. Okay? I don't know which one that is, but you guys are going to find out. But for me, it's more like I'm putting my hand on their shoulder blade. I'm feeling their border like this, and I'm rotating them so that their border is lining up with the humeral head or AC joint, whichever one. That's how I do mine. Okay.
Is the PA just another version of it, or
The
that?
PA is.
Okay.
Yeah. That one's not to be tested on, but that is an alternative.
Okay.
Yeah.
So you started with the external, internal Y view, right?
Yes, I did. I'm going to jump into the Grayshey now. Okay, my good man. Have you come towards me? Here we go. So we do need to have an oblique.
Yeah.
Okay. I know we didn't do it on the mannequin, but that patient was oblique for the radiograph. Why? Because we need to try to open the glenoid cavity. Why? Because the rims, if not, will not be superimposed. So you can see how the rims are in a natural state of the shoulder blade, right? So that's why we have to rotate the patient so that those are superimposed now. Maybe we can get a nice opening of the glenoid fossa. So let's rotate you, my friend. There we go. How much? Well, I'm going to guess probably 35 with you. All right. Doesn't matter if it's portrait or landscape because you're going to column it down anyway, so it doesn't really matter the orientation of it. What does matter is that you want to go at least about a couple inches from the AC joint. So probably about 2 inches is good. Not too bad. Getting right there. And then 2 inches, in the book it says 2 inches from the lateral aspect of the soft tissue side of the humerus. So I think that's right about there. I normally like to go the AC joint to give me more of that medial centering, because I don't know how to do that part. It just kind of looks weird to me. So usually if I go over the AC joint and I go inferior from it, I'm right about there. Okay, maybe give or take a few centimeters, I don't know, but trust me, you're gonna be in that area. You just feel for the AC joint, that bony prominence there. Okay.
Right there. Right there.
Oh, I need to go lower. There it is. Okay, good. Arms in a neutral position. Let's collimate down. Look at this. I know that the glenoid cavity is not there, so I'm going to collimate to a nice little square. Left market placement. You hold still right there, okay? Don't move. Yes. Good.
Good job.
Just like that. So arms in neutral position. Some places actually like to have the arm abducted. Just depends on where you're at. Just depends on the provider, really, too. Orthopedics, they have funny stuff. And they'll throw some old school stuff at you, too. Weird things. But, you know, just all depends on what they want. Any questions on that one? No. Pretty cut and dry, right? Oblique the patient. Center the patient. I like to go from the AC joint about 2 inches down. Okay? 2 to 3, whichever is your preference. And then it says 2 inches from the lateral aspect of the humerus. That one's a little bit harder for me to do, so I just normally go from the AC. It just puts me in the area. It really does. And then just call me in. Not too fancy. Just call me right there. Oh, thank you. Wasn't expecting that. I like it.
Standing ovation.
Yeah, we're gonna switch up to the right shoulder for just for this purpose. Okay, so you can see it. I'm gonna have you turn around so you're facing the board there, sir. Thanks. Oh, look at it. Man, you already know what I'm gonna do, huh? I like it. All right. This is the axillary. We're gonna have you raise your right arm towards the ceiling, nice and high for me. I'm gonna feel the delt dip. Look at that. Yeah, delt dip. Been working out, huh? I see you lying, man. You didn't have that last time. All right, partner. So what you're going to do is you're going to rotate the patient just a little bit, 5 to 10 degrees internally. Make sure he's still lined up. Very good. Call him in. Look at that. Collimation's the last thing. I love it. If you want to know how much, I can't tell you, but we are just looking at this glenoid, I think they say glenoid, scapulohumeral thing. I don't know. I can look at the book.
The glenoid
Glenoid scapulohumeral joint or something like that.
Oh yeah.
So we're looking in that area. You guys may want to look that up and you tell me. But it's that thing right there. Make sure to rotate them so the axillary is closer to the IR. Having them flat is pushing them further a little bit away. So we do have anterior oblique. Booyah. Just going to bring your arm back down. Any questions on that one?
What view did you say this was?
This one is an axillary, so raising that right arm up, and then you're going to do a slight anterior oblique, pushing that axillary closer to the IR. Was that your question?
Yeah.
Okay. Yes, your question?
No, it's just so literally just have them like this and then slight side oblique
anterior oblique,
towards the IR.
Yep, bring that arm up nice and high. Yeah.
And then you said there's not a right amount of collimation, but just make sure you get the anatomy that we're looking for.
Correct. So you don't need to have a whole bunch, like, past the ear or anything like that. If you're centered correctly, you can collimate down efficiently.
Okay.
But what happens is, if you're not centered correctly and you do still collimate and you're well, let me rephrase this. Let's say you collimate and you miss the anatomy and you're like, damn, wait a minute, but my collimation is nice and square. Well, then you weren't centered correctly.
Okay.
Okay. So centering is key. All right. Trauma shoulder. All right. So this is the one with that transthoracic. So we have the AP, we got the Y, and then the transthoracic view. Just go ahead, boom, just like that. This does not require a sponge. Have your back up against there.
Are you gonna label them, Lloyd?
It's all one long video. I'll throw it up one long video.
The centering for shoulder is the same thing as a regular shoulder. We just want to go like 1 inch below the corporate process. I'm going to move you over just a tad there, my friend. There we go. I'm going to feel first clavicle. It's just a lot easier for me. Man, I'm right there again. I've done these once or twice. I think that's too much of a 12. I don't think I'm right. Okay. So I want to get that jugular notch in the light. He can fit in this so easy, no problem. We're not going to move his arm. It's a trauma, so we take as is. Okay? So this is a neutral position. I'm going to bring that arm just down. There we go. This is a neutral AP position, yes. Trauma. So we leave it in a sling. Okay? Set it up for the Y view. 10 by 12 portrait. Let's go ahead and rotate your body. Don't need to move the arm, but I'm just going to move the patient Still trying to mimic exactly how I normally do a Y, filling that medial border to the line up to the AC joint. Let's get a little bit of light above the shoulder here. This border's right about there. Easy. I'm not going to collimate for this one. It's trauma. I'm going to give him more information. Center ray over the humerus there.
Which one
Okay.
is this one?
This is a Y view trauma. Not moving that arm. Remember on the Y view we moved the arm across this way? But it's trauma, you leave it as is. Don't no touchy. No touchy. Deers in the headlight. No, I need to stop. Tell me.
So you just leave it like that.
That's it. Trauma. Trauma. You don't touch it like that. You just let them stay the way they are, and just rotate the patient, and just do the best you can with the Y. Okay. Good. All right.
It's getting echo.
So I'm going to have you turn and face me, please. Just align that. There we go. So transthoracic lateral, this is for the left shoulder. So we want the humerus, the affected side, to be closest to the image receptor. You're going to take a step towards me, please. Thank you. And I have a slight oblique. And the reason why I do this is, the reason why we do this part is because we want just a little bit of light above the shoulder. Having it up this much, there's nothing up here that I want.
Right.
I'm going to utilize the full 12-inch length, though, to be honest with you. I'm not going to collimate. I'm going to want to take the full advantage of it. So I'm going to give them more information even down here too. Okay? So bringing that, just a little bit of light above the shoulder is going to achieve that goal. Alright, so now I'm going to put the patient in a true lateral. Using these crosshairs on the image receptor, I'm trying to place his arm in directly in the middle of that AEC. Okay, it doesn't feel like you're quite there yet. Yes, okay, do you need to take a step forward? Let's do that now. Okay, good job. Good. Gonna have you go and bring your arm up above your head, just to extend it nice and high. Keep it like that, my friend. Breathing technique, you don't need to tell them to hold their breath. We want them to blur the images. We want to see the blurring of the lung markings and stuff like that, so it's gonna be a lower MA station. All right, there we go, just hold really still. We're gonna go and take that exposure right there. Good. You can bring it down. I can't resist a high five. I did it last class. I love it. Any questions on that transthoracic? Just
So they're
simple.
not obliqued at all for that one.
No,
They're
put them in a
straight.
perfect lateral.
Okay.
And you want them directly centered too.
Right.
That humerus to be directly centered in that AEC chamber. Or else it might, mess up your whole MA station. It might be cut short. Things like that if they're off center. Cool. Any questions regarding that?
No.
Janice girl. Any questions?
No, I'm good.
All right. I want to make sure I'm not.
I want that one for the test. I want to pick over and pick that one.
Trauma.
The clavicle. That one.
Oh no, clavicle girl, that was a trauma shoulder.
Huh?
No, she's saying she wants a clavicle and a
Yeah, I
trauma.
want
So
that.
let's get into it then. You want?
I want that one.
You want that one?
I'm praying for what I want. I'll get it.
Okay. Well, let me show you what you're gonna
Stop
get.
praying now.
Let's jump into it then. Let's do the clavicle, the one that you're gonna get then. Let's see. Let's put your back up against the board there. The clavicle is one of the easiest X-rays, close to a bone age study. Have you guys done a bone age study yet? No, just that way, and it's just one view. The only one view that I've actually ever
The
seen.
one that guy he was so dumb. I just let him.
Oh, when he was
Because he
trying
was
to tell
telling me
you.
a hand first.
He said a hand
He
and
said
a
a
arm.
hand. Then he said it's not a hand.
It's
So
a
you
hand and a
should
wrist.
just say, just tell me it's a hand, and then just go up a little bit more.
Yeah.
He was yelling at
Yeah.
me.
That's his.
I'm like you,
Yeah.
whatever.
He got like that because he was like, you know how to rotor? Hold the head. And then he was like, keep pressing it, keep pressing it.
He has
That's a rotor.
issues.
And then I pressed it and it
He has
exposed. And he's like, why'd you expose? And I was like, you told me to push the button.
Yeah, he said it's a hand, but not a hand. Just tell me, just go up a little bit
Hand, I
more.
want you to do a hand, but to here.
He's in there just pooping up himself. I'm like, oh no.
It's alright.
Well, yeah, the bone age study is one of the easiest ones out there.
Yeah.
This is the second easiest one. All right, so I'm gonna censor directly on the clavicle here. All right, he's got that nice straight clavicle. You might get some patients here that have that kind of angled clavicle, so therefore collimation is going to be an issue. You don't want to get too fancy. But with him, I can tell you right now, I can get a little fancy with it. All right, Jugular notch is right here. His AC joint is right here.
So that'll tell you the angle where the AC joint lines up with the jugular notch, whether it's straight or not.
I wouldn't say, well, maybe you're right. I would tell you the angle when you do for the axial. You talk about for the
I'm
axial?
talking about for this.
For this one,
AP.
it does tell you the angle of the patient's clavicle.
You
if
can
it's-
feel the end and you can.
Correct, yeah, you can be able to determine the angle. So I'm feeling just across it, just across the way.
If I'm like this, you can see it go up.
Good job. Okay, so what's going to happen here is I'm going to center in between my fingers. Here's my centering here. Looks pretty good. Let's collimate then. This is going to tell me if I did a good job or not. Look at that. Look at that.
He's feeling himself.
Yeah. Can I expose this? I want no. I just want to see.
Will you sign this real quick, please?
I know, and
Give
we
him my
can
shield.
get
Give him my shield. I didn't do it. I'm just kidding.
Is it thyroid?
Okay, here we go. Left marker placement. I don't need to do anything else. Just hold still, man. Boop. It's done.
Put your
All right. Now, can I angle this?
Oh yeah, it'll stay.
Okay,
You're
great.
good.
Angle 15 degrees for the test. Just angle your patient 15 degrees for your test. In your book, it tells you, depending on the body habits of the patient. I'm going to center just a little slightly inferior from the clavicle. Nothing major. Don't forget to move this. That's the only thing you really need to worry about. Patient is exactly where I left them last time. Okay, he didn't really move out of position. And then expose it. AP axial. Just don't forget to move this. This is probably maybe the biggest one. I know this is really easy. We used to do this 2-on-1 back in my day. When we used to have film, I enjoyed these because it was a challenge. I used to use a 10x12 and we did them 2-on-1.
Oh, 2 exposures on the same film. Oh.
2-on-1. We get real fancy with these. So you want this one too, huh? All right.
And the reason why you raised it is because you're getting an angle, so you have to compensate, right?
Yeah, because your light's going. Your beam is
'Cause you're-
going.
Yes.
wanna go
did
like
you,
this.
okay, so stay right there. So did you, when I angled it, oh damn it. Well, okay, so when I started from the AP, my bucky was here.
Right.
When I angled it, my line was up here, so I had to raise it up to line it up.
Right. So if he steps away, it's perfectly centered. So
Yes.
okay,
Yes. Yeah. Oh yeah. That's
That's what that
key.
light.
That's key, guys.
gotcha. Okay. All right. Thank you.
You're welcome. You're welcome. All right. Let's see here. Let's just jump into this scapula. Sound fun? All right. Let's see. We're gonna go 10x12 portrait because we just care about the scapula, the shoulder blade. That's it. We don't care about the clavicle now. We just want to go 10x12. All right. So have your back flat up against there. So in the book it says to at least have like 2 inches above the shoulder. I guess this is just a lot easier to do it this way. Yeah, I agree. I think it is. And there's another way too, but 2 inches above the shoulder is it's all you need there. We're gonna bring the arm and abduct it about 90 degrees or so. In the book it shows you the hands placed on top of the head. Can we do it like that? There we go. And then we're gonna go 2 inches from the lateral aspect of the thorax there. So it should be right about there. Look at how much light we have here. We can actually collimate in. Get a little too fancy, that's good. I'm gonna stop mid-sagittal plane. I can actually move them a little bit more this way.
So right on the other side of the jugular notch.
Right. I was gonna keep going this way. Let's put it this way here. So his arm should be raised. He's moving that shoulder blade a little bit more flat, parallel to the IR. It kind of moves it a little bit away from the ribcage. Not so much, but it does. 2 inches of light above the shoulder. The book says 2 inches medial from the lateral aspect of the thorax. Okay, I'm gonna bring that arm down. I'm gonna reach across to the opposite side. There we go. And then it's just a wide view. There it is. See, we have no light above here. You've got to make the adjustment. Let's get a little bit of light. I want to be certain here.
You still feeling for the bottom of the?
Yes, it's
Scapula?
right there.
Okay.
It's right there.
Oh yeah, you're in there.
I got plenty. It's time for me to stop messing around and get down to the nitty gritty there. I'm rotating him. Look at that. Let's move this down. Fantastic. Might be a little bit more of an adjustment. Uh-oh. I feel better now. There it is. Wipe it. See how the shoulder kept creeping up a little bit? If that happens, bring the tube up, bring that up.
Just to make sure you catch it.
Yeah, because you can go relax. Do you know what these structures are called?
The
Because-
acromion?
The acromion, right?
Yeah.
There's the coracoid, right?
Yeah, it's cool.
You're gonna, if you don't bring that eye up a little bit, most likely you might clip the acromion. So that's why I do that. And bring it up a little bit more. That's the scapula. Any questions on that one?
So if we did the wide view before on the shoulder, do we still have to do it again on this one?
No, if you did the wide view, like say for example, if you picked a scapula and then a shoulder on the test, you only do one Y. That's fine. That's it. All right. So the AC joints are the only thing that's done at a 72-inch SID. Can you grab that 14 by 17, please? Let's do it this way. Can I have you hold this up against the IR like this for me? Just hold it right there like that. Don't let it fall, okay? Perfect. Hold it right there. I'm just going to do it this way so I can actually get a good measurement. There we go. Just that. Thank you. So this is a 17-inch length. I'm going to have your back up against there, please. So this one is with and without weights. 72 inches. I'm going to center lengthwise across to the clavicle here. And then he's going to be centered mid-sagittal, or if you want, directly in between that jugular. Okay? All right. Pardon me, my friend. We're going to feel for those AC joints. It's nice and bony right there. I'm going to just jog it down a little bit. Look at this. I'm wiggling my fingers just to help indicate where his AC joints are at. Maybe we should just do that just better instead. So we know for sure we're going to get him in there. I have some really big ears. All right. See that? See how big my ears are? Look at that.
It's magnification.
Jesus. I mean, I know it's magnification, but like, I didn't know something like that.
It's the mask, really.
It's the mask, yeah.
Yeah.
Like
Say that.
His clavicles are right here. I can actually make an adjustment. I'm a little bit inferior. You know why I'm going to change it? Because I like to get fancy. That's the kind of person I am. Let's collimate. I don't need his face. Collimation is the last thing we're going to do. I'm happy with everything that I've done at this point here. I'm happy for you too because you're doing such a great job. So, with this one here, we take this without first, okay? And tell your patient to hold really still, don't move. Go back there, expose it. If you already have like these auto cells that say with, and then you have another one that says without, I still would prefer that you do an annotation if the tech lets you. Just because if you pick the wrong cell by accident, you just defeated the purpose of it.
Yeah.
Okay? And then when you try to fix it, you might run into a problem there. So when you take your first exposure, just annotate on it. Just put without. It's that simple. It doesn't take very long. After you make that first exposure and you're done with the annotation, come over to your patient, hand them the weights gently. There we go. And then we're going to bring those shoulders, so you relax those shoulders down. And those weights are going to bring the person down. Like that. If you see guys are doing this, just like this, you're shrugging, tell them, say relax. Say relax. No, like with conviction, say relax. Relax. Yeah, relax.
There you go.
Relax. Like, I know you're strong. There's no depression, but relax. Shoulders are going to drop. Expose it. And then say, go ahead and drop them. Go ahead, just let them go. Boom.
My foot.
Let them go. I know, huh? Oh, that's my fault, you're a moron. Yeah, just throw them. Just go to let them go. No drop them. And then that's it. So the width and withouts. The only one done at 72 inches. Okay. If you have someone who has broader shoulders, you can't fit them all on one day. You'll have to just do it individually. Very. I don't think ever. I think maybe only one time ever did do that for somebody. But if you have to do it that way, you might just do it individually. And that, I believe, is all of them. I think so.
Okay.
Yeah, our class is done. No, I'm kidding. All right. So we're gonna go ahead. Any questions regarding that? No. Did you need to see any of those?
No.
I
think
think
Yeah, we're close to that.
Yeah,
Yeah.
almost.
Oh, thank God. Okay, great. I'm kidding. No, okay. Okay, good. So, if you guys want, we could take like a short 10-minute break. Okay.